Good morning. Hi, I'm George Johnson. I don't know if you realize this is the first Saturday that you guys came here and didn't have to put on your sunglasses. In over a year, we've had sun every meeting time, and this is the first time. Maybe it's because it's kind of a special event. What we're going to do today is we have our speaker who has was given an award last year. Is called, I don't know how he likes it, called Top Doc by a medical publication. But we're going to schedule him to kick it off. I have a few things to say, and then after he departs, we have some more information for you and some, if you will, breaking news, breaking good news, and. So we want to thank the Sanford Burnham Previs Discovery Institute for providing us this facility. And I remember our speaker spoke here earlier this year for a wonderful presentation, and maybe we'll hear segments of that today. And hitting it off right off the bat, for him, this is our traditional profile of treatment. And if you will, I'd like you to raise your hand, and you can see that. This is for you. I don't know if you can see that. Okay. We're going to do a treatment profile. And how many have not had any of the treatments below that other than they're on active surveillance now? Raise your hand. Okay. And it's a good number. That's a growing number. How many have had prostate surgery of all kinds? Raise your hand. Now let me break that up between open surgery, raise your hand, and robotic surgery. See, that's the trend we're getting here. And then radiation of all kinds, raise your hand. And then we go into ADT. Generally, that follows how many? We've got a lot of ADTers. That's me too. And how many have been or are now on chemotherapy? Okay. New treatments. Provenge, HIFU. By the way, on HIFU, anybody had HIFU here today? We have a member that wants to talk to him about it. Well, we don't. No HIFU. But now we have cryo. And the new series of drugs, Xtandi, Zyfigo, and so forth. How many are on the new stuff? Yeah. He's on everything except chemo. Okay, let's do recurrence. How many have had a recurrence? That's why you're here. Recurrence. I know how you feel. I had radiation. Back then it was called EBRT, and after 10 years it came back, and I thought I was cured. What's this idea of coming back? But that's why you need to have a PSA test, because it can come back. Okay, how many are undecided what to do next? Okay, hopefully you'll get some information today or in the following months on information about what's new. Okay, I have a suggestion. It's time to get some money from you folks. Let's pass the baskets. We're a nonprofit, and we need to get an average of $10 per person to keep this operation going. So if you can't make that, we understand, and if you can overdo it, we certainly appreciate it. But this activity that we conduct here is on a very economic basis, and we have a lot of contributions and volunteers that keep it going. And did we get this front row? Okay. Right behind you, there? There we go, just like you do in church. Maybe we ought to get a long handle on baskets. We are not affiliated or associated or get any funds from any drug outfit, medical institution, we're totally independent. So we're dependent upon you, and there's no salary or money exchanged or anything like that, but we really get a benefit. It's a wonderful benefit. So if any of you want to volunteer, see me after the meeting.
Sure. Crank my volume up.
And as much as you can give, we certainly appreciate. We've been very viable and able to continue our operations due to your generosity, and we appreciate it. We have 10 volunteers that come here because they want to help. And this is now, we're in prostate cancer era of new and different, and we'll have some comments about some new drug after Dr. Kane has to leave us. And now, we're going to have Gene get forward here and introduce our speaker. I'll use this. Okay.
Can you hear me okay now? You got me? Okay, yeah. Good. I think this is the second or third visit. I'm not sure.
Fourth time I've spoken.
Fourth time? Yeah, okay. That's wonderful. So, Dr. Kane joined UCSD in 2007, and since then he has become Dean of Clinical Affairs, CEO of UC San Diego Health Physicians, Professor and Chair of the Urology Department, and he's the inaugural holder of the Joseph D. Smith, MD Presidential Chair in Urology, which is an endowed faculty chair. I'm not sure if you do windows or not. Yeah. Please welcome Dr. Kane. He's a good friend. Right.
Thank you, Gene.
You bet.
And it's a pleasure being with you. I have many friends, patients, acquaintances in the audience. And, you know, it always, I think, is sort of impressive when we think about prostate cancer and we think about cancer in general. You know, we go through stages of life. When we're in our 20s and 30s, we're invincible, and cancer is something that we think about, you know, out in the future, or an occasional unfortunate person may get. And then as you age and you live life and you have kids and you take care of aging parents, the prevalence starts to become part of your awareness. And the fact of the matter is about half of men will have a diagnosis of cancer in their lifetime. Not prostate cancer, but when we talk about all cancers, and a little more than a third of women. So when we think about investing in prostate cancer research and encouraging political activism to drive dollars toward NIH and NCI budgets, which is, you know, one of my focuses, it really is about the care of ourselves, our brothers, sisters, our family, our parents. You know, it's a ubiquitous, nearly ubiquitous problem. And why does it seem to be getting more common? Of course, age-adjusted incidence is not going up. It's actually going down slightly. But the overall incidence and prevalence is going up. Anyone have a thought about that from a population-based perspective, why that might be? More effective treatment of cardiac disease, right? So as we age, something's going to get us. So as we survive cardiac disease, and as cardiac disease gets more effectively treated, some of the malignancies associated with aging become more common. And so that's really one of the things that's happened with prostate cancer. Even though in the PSA era, I'll show a couple slides that show that when we started in the PSA era, the mortality of prostate cancer went way down. In general, prevalence of malignancy is going up as we age. So it's a problem that is common. I wonder, I might just take a moment to pitch in. Do you see it?
We're just trying to...
Okay. So today, what I'll do is talk a little bit about the changes in 2018. What's happening in prostate cancer? And I was heartened to see so many men on active surveillance. So one of the big changes is, of course, the U.S. Preventive Services Task Force shifted from a D recommendation of PSA screening that those of us who were pro-screeners really disagreed with, to a C recommendation. And C doesn't sound that much better, but basically C means that men should have a discussion with their physician about the risks and benefits of screening. So that's a movement in the right direction. Why did that change occur? Why did the Preventive Services Task Force feel a little more confident in the C recommendation? Well, in order for you to understand that, you have to understand why they gave it a D recommendation. They gave it a D recommendation for two reasons. One is the large randomized trial of screening versus no screening done in the United States, called the PLCO trial, was not a positive trial. There was an equal number of prostate cancer deaths in the screening and the non-screening arm. And the screened population got a lot of treatment, many of them getting overtreated for low-risk prostate cancer that was probably never going to cause harm. So the U.S. Preventive Services Task Force, perhaps correctly, looked at that data and said, wait a minute, randomized trial shows no improvement in mortality, and a lot of men got treated, and there's some harm to treatment, we all know, sexual and urinary challenges. So there's more harm than good to screening. Well, the problem with that is the PLCO was a pretty flawed trial. It turned out, when you looked carefully at the people in the non-screening arm of this randomized trial, nearly 90% had a PSA test. So it really showed us not that screening didn't work, it's that you couldn't do an effective screening trial in the US, because men who were interested in enrolling in a screening trial wanted to get a PSA done. So I should always spend a moment with disclosures, research funding from NCI and Prostate Cancer Foundation. By the way, the Prostate Cancer Foundation meeting is again in San Diego at La Costa in just a few weeks for the 5th year in a row. Financial relationships with Genome DX, Genomic Health, MDX Health, and SNP Bio. And in general, these are financial relationships where they invite me to do consulting. I don't have a financial stake in their success. The one investment that I have that I will talk briefly about, one of their products, is SNP Bio, and I'm an investor in that company. So these are the big changes that I'll talk about, and I was just delving into better screening and avoiding overtreatment, and I was, again, delighted to see a number of people on surveillance. Improved tests to enhance specificity, so that means do a better job of diagnosing men with prostate cancer when it occurs the first time they have a biopsy. So we're trying to get away from this pattern of men getting 2, 3, 4, 5 biopsies prior to their diagnosis. And if I had people raise their hands, how many people not on active surveillance required more than one biopsy to diagnose the prostate cancer, I know from our population-based data that over half of the men here have had more than one biopsy prior to their diagnosis. So we're getting away from that, and MRI has really helped in that regard. The MRI technology has been a big improvement, and it's actually changing the way that we diagnose newly diagnosed men, and I'll comment on that change. Treatment of localized disease has also improved, I think, with lower side effects and improved outcomes. That's true of surgery, which hasn't changed a lot in the last 5 or 6 years because we've been doing robotics now for about 10 years. I think the main change in surgery is probably more extensive lymph node dissections, and there's some data supporting that. And probably urologists, there's pretty strong data that if you have surgery, you should have it done at a high volume center by a high volume surgeon. And so I think a little less surgery in the community by low volume surgeons is a positive trend because their outcomes just can't be quite as good as higher volume centers. And I think radiation oncology has improved a lot. The big differences in radiation therapy have to do with technological improvements that allow dose escalation. Every time we do a randomized trial in radiation comparing a higher dose to a lower dose for at least intermediate risk prostate cancer, the higher dose is always better oncologically. And that's been true. There's a series of randomized trials that the RTOG, the Radiation Therapy Oncology Group, has done. The prior standard of radiation therapy was about 70 Gray to the prostate. And that standard occurred that was over 20 years. Now the standard dose is 81 gray, and now sometimes we're accelerating that up into the 85 to 90 gray range. To do that, we will really cause a lot of side effects unless the technology is quite sophisticated. And so dose escalation, improved targeting, that's only possible with better IMRT technology and proton therapy. Very similar to IMRT, it allows improved targeting. So I think radiation therapy has also gotten better, and better oncologic outcomes with more limited side effects because of better dose escalation, target movement accommodation. And then improved imaging of advanced disease. And I think many of you in the room have probably had PSMA scanning and other modern PET scanning that has really emerged as a useful tool for earlier diagnosis of advanced disease. Now, we don't always know what to do with that new information. And I'll share with you that there's a couple of randomized trials that are currently enrolling for men with newly diagnosed advanced disease, where we're exploring the use of whether we should treat localized disease in a man with newly diagnosed metastases. That's an unknown right now, but there's a large randomized trial that's being entered. And then how about men with a PSA recurrence and what we call oligometastatic disease on imaging? That means one or two areas that show up on imaging. Is there value to going after those one or two areas with surgery or radiation therapy? We don't know. There's an interesting phenomenon in cancer outcomes assessment called the Will Rogers effect. I think many of you are aware of the humorist from the mid-century, Will Rogers. He famously said when the Okies went to California, the IQ of both Oklahoma and California went up. You got to kind of think about that a little bit. It's an insult to everybody. But the reason that's called the Will Rogers effect, when we're thinking about the outcomes, if in the old days we were treating someone with radiation therapy when they had a standard bone scan and a CAT scan that was negative, and let's say a third of those men recurred over time, we called those men localized, no evidence of metastases, and a third of them recurred. Now, if we enrolled a similar group of men and we do more sensitive testing, we're going to say a group of those men has metastatic disease. We can see it because our testing is better. And those men are excluded from the assessment because we're only looking at men with localized disease. So what you're doing is you're excluding the men with the highest risk disease when you're assessing the outcomes today. So you're really looking at the outcomes of a different population. Guess what? Radiation therapy or any treatment, when you have a more refined population, will appear to have better outcomes. It is a bias. It's a bias because our imaging is more sensitive, so we're including fewer patients with advanced disease in that treatment up front. So the outcome of the same therapy today might look like it's 80 or 90% effective. Really, it's not any more effective. We've just refined the population. That's the Will Rogers effect. It's actually true in any treatment of malignancy when your diagnostic testing is more precise and you're refining the population that is being treated. It's a complicated concept, but it's quite valid. So we always have to be careful claiming new treatments are better when at the same time our assessment is more rigorous. Okay, risk stratification. Now, why is this such a big deal? There's no disease where risk stratification is more important. What do we mean by risk stratification? In every malignancy, we use the terms stage and grade. Stage means physically where's the cancer? Is it localized? Is it in lymph nodes? Has it spread to bone? Grade means when we look at the individual cancer, wherever it's biopsied from, how aggressive does it appear under the microscope? Now we have really more information than grade for aggressiveness. We can look at genomic testing as well and look at the genes that are abnormal, and that correlates with outcome. So when we think about risk stratification for newly diagnosed man with prostate cancer, if he is a classic candidate for active surveillance, his PSA is under 10, the volume of disease on biopsy is low, the Gleason grade is only 3+3, and the PSA density is low. That means the PSA divided by prostate volume. I'll talk about that in just a minute because that's often a confusing concept. If a man meets all of those criteria, what do you think his chance of dying from prostate cancer 10 years if he's carefully observed on active surveillance? Anyone guess? No, it's not quite 1 in 1,000. It's a little under half of 1%. And what data am I quoting? I'm quoting the Johns Hopkins active surveillance data. So Dr. Epstein included only people who met very strict criteria in active surveillance, and as long as they were carefully followed and any men that appeared to progress were treated, the actual mortality was about half of 1% at 10 years. If you're a little more liberal and you include men with a little higher grade disease, a little low volume Gleason 3-4, especially in men older than 70 or 75, but otherwise meet all the criteria, that's the Toronto experience. Their 15-year mortality was about 3%. So if you start to include intermediate risk disease in active surveillance, there's some men who won't be effectively treated. It's not quite as safe. But the concept is if we do autopsies on men who are 70 years of age and get killed from a biking accident or pneumonia or some other cause of death, and we do an autopsy, about half of men at 70 years of age will have microscopic low-grade prostate cancer. Half. That means low-grade prostate cancer is a normal accompaniment to aging. It's a normal accompaniment to aging. Therefore, we should probably call it something other than cancer. When we use the term cancer, it implies to the patient and to physicians that there's biologic risk, that there could be a metastases. And of course, we know when we look at newly diagnosed men, there's a portion of them we misclassify. There's some challenges with active surveillance, the repeat assessment, repeat biopsy, but epidemiologically, those men with microscopic foci, that means little areas of low-grade prostate cancer, that is a condition of aging that should avoid treatment. We should avoid treatment. So that's one end of the spectrum. On the other end of the spectrum, I operate pretty commonly now on men with high-risk disease. And I just took care of, very recently, a man in his early 50s, first screening PSA over 20, first prostate biopsy, Gleason 4+5, high volume disease, radical prostatectomy, nodes positive. So on that end of the spectrum, untreated high-risk prostate cancer, 10-year mortality is more like 30%, 40%. Now we're in a zone where it's difficult to successfully treat that patient and deliver a cure. We can always prolong life, reduce the burden of disease, but in his lifetime, will prostate cancer be the cause of his death 10 or 15 or 20 years from now? Yes, it's much more likely than that low-risk patient. So what's the difference between? It's risk stratification, right? So risk stratification are standard tools, PSA, grade, stage, number and extent of positive biopsies. Gleason grade's a very powerful predictor of outcome. We all know that. There's been a little bit of migration of Gleason grade. Now we use genomic testing to really kind of help us refine risk. Genomic testing, there's commercial products, Decipher and Oncotype DX and Prolaris, each looking at different genes but doing a similar thing, helping us risk stratify. So there's no disease where risk stratification is more important. It's on one end of the spectrum, it's a normal accompaniment to aging. On the other end of the spectrum, it's the second leading cause of cancer-related death in American men. So what are the tools we have? So now these are the genomic tools that we have to try to categorize risk. Let's go through them just a little bit. How about who should be screened? I don't know if you're frustrated by the mixed information. Essentially everyone in this room has prostate cancer except the spouses and the support teams that are with you. But an important question is, should your son be screened? And how about your grandchildren? What's their risk? So rocking and rolling. So in general, we recommend screening for men with primary relatives with prostate cancer. How about if your dad has a bad prostate cancer? Does that increase your risk? How about if your grandfather died of prostate cancer? Is that different than prostate cancer that was just diagnosed? Well, so if you have a primary relative with prostate cancer, it just about doubles your risk that you'll be diagnosed with prostate cancer in your lifetime. But currently, there's no strong evidence that the cancer is going to be worse if it's an inherited cancer. Now, I'll talk if there's any questions about BRCA and genomic acquisition of risk. That's a little bit of a different topic, but most heritable inherited prostate cancer is not a high penetrant syndrome. It's not a gene, one single gene that you can acquire. There are some syndromes like that. The Hoxbox gene that was discovered again at Johns Hopkins, very high penetrance. When that happens in families, every man in the family has prostate cancer. It's an autosomal dominant acquired cancer, and it's like some of our other genetic diseases, but that is extremely rare among the group of men with prostate cancer. I'm sure nobody in this audience, be interesting to hear it, if anyone knows they're Hoxbox positive. Does anybody happen to know that? Yeah. So if you have one of those families where grandfather, uncle, dad, and two brothers have prostate cancer, you should undergo testing because it's important for your children to know what their penetration is. Autosomal dominant means that 50% of your offspring will have that gene and have prostate cancer. But most inherited prostate cancer isn't that way. So what are SNPs? Those are called single nucleotide polymorphisms. The company that I mentioned earlier, and there's now a couple of different companies in this space, are looking at the SNPs that you inherit from your parents. They're little variations of your DNA. And we can go back and look at SNPs, and it turns out if we look at a particular pattern of inherited single nucleotide polymorphisms, we can categorize your risk of prostate cancer. It's very controversial whether we should be doing this. We can look at the SNPs that describe your risk of Alzheimer's, the SNPs that describe your risk of diabetes. And this is your inherited genome. It's different than the test that we do on a tumor. That's what we call somatic mutations. It's the tumor abnormalities. This is your inherited genome, meaning we could measure the SNPs in a baby and categorize that child's risk of prostate cancer in the future. That categorization is now quite precise. We can do a really good job. If it's family history, no family history, we're talking about a doubling of risk. If we look at your SNP profile, we can spread out that risk to 5 times the population to less than 1/4 of the population risk. And I'll show you a graph. Isn't that fascinating? Yes. And the question is, who gets to know? Does the insurance company get to know this? I hope not. When are you going to test? All of you with prostate cancer with children and grandchildren, aren't you curious? Did they acquire your risk or not? Now we have the ability to tell them. So we think the sweet spot is probably testing family members of men with prostate cancer. Right now, the screening recommendation is we should screen men with a family history and we should screen African American men. Why? Because we know that group of patients has a higher risk. And the higher your risk, the better screening is, the better it performs. If you're at really low risk of having a bad prostate cancer, you're more likely to get diagnosed with low-grade disease, get biopsies, and spend a lot of money and have a lot of morbidity, but it's not going to save your life because you really weren't at risk for a bad cancer. So your pre-risk assessment is really important to decide about screening. These are different serum tests that do better than PSA to select first biopsy, and of course, very importantly, now MRI is done before first biopsy. Decipher, Oncotype, Prolaris. These are tests done on tissue that help us get, it's kind of like a augmented grade. Then after surgery, to help decide whether you'd be a good candidate for radiation therapy, Decipher and Oncotype and Prolaris are good tests. Decipher is probably the dominant test in that space. And then when you advance disease, there's some evidence of this ARV7 being associated with your response to abiraterone or lack of response to abiraterone. ARV7 positive patients should go to chemotherapy. This is an area where there's a huge amount of research doing personalized medicine and understanding, we don't really know right now if somebody has a recurrence after treatment or is newly diagnosed with advanced disease and after ADT they start recurring. We don't do a great job of picking, should we use docetaxel or cabazitaxel or enzalutamide or abiraterone. Our hope is in the future with people like Dr. Raina McKay at UCSD and other really talented physicians, we're trying to sort that out by looking back at the outcomes of men with known outcomes after these treatments and then looking at their genomic risk so we can look at predictors of treatment in the future. Right now, when we look at sort of the NCCN guidelines, you know, we make these rough recommendations, but it would be much better to understand exactly which patient is going to have a great response to abiraterone and who's not. And so both selecting great responders and trying to eliminate poor responders. We don't want to waste someone's time on a drug that's ineffective. So there's a huge area of research here. So impact of PSA screening, I mentioned this at my opening remarks before we had the slide up. This is the introduction of mammography and breast cancer mortality over time. Excuse me, incidence, not mortality, over time. This is PSA screening. Incidence of metastatic disease, excuse me. This is PSA screening and newly diagnosed metastatic disease for prostate cancer. That's 2010. I think, unfortunately, after 2012, between 2012 and 2016, there's a little bit of evidence that this is going back up. And that's why we're really heartened to get that C recommendation so we can start to re-educate our primary care doctors to re-embrace prostate cancer screening. But if you're a prostate cancer screener, you can't be a universal treater. Too often in the urologic and the radiation oncology community, we embrace screening, but we were over-treating low-risk disease. So we have to separate the diagnosis, risk stratification, and treatment. And that's why, again, I'm heartened to see so many men on active surveillance. About 40% of newly diagnosed prostate cancer patients should be on active surveillance. We know that just from population statistics. This is the prompt PGS continuum of risk. This is the test done on the 1,654 men with prostate cancer in the PLCO. This is a publication that was in JCO. And this is their risk allele, the likelihood of that in the population. So you see, you get way over here with the estimated risk of prostate cancer being super high. That's all 33 SNPs positive in these people. But the chance of being in that really high risk is only like 1% of the population. I think what's really interesting is if we look at the value of this, if you think about testing our children or testing a group of men considering screening, is this group at really low risk, their estimated risk of prostate cancer is, under 10%, they probably should not have any testing. They probably shouldn't even have a PSA done. This group, certainly this high-risk group benefits from screening for sure. It's a little bit controversial. I would do probably age and health assessment for this in-between group. Again, this is the idea. We want to screen these high-risk patients, periodically screen the middle-risk patients, maybe every 2 years, maybe skip screening for the bottom of 25%. Okay, how about MRI? So as everyone, I didn't want to go through the entire study, the precision trial, but I'll just summarize it briefly verbally. The standard for MRI before May of 2018, what was MRI used for? It was primarily used for men who had a prior negative biopsy. So if you'd had a previous prostate biopsy for an elevated PSA, and your PSA was now rising, before you had a repeat biopsy, we would do an MRI, and if there's an abnormality, we'd make sure that repeat biopsy was focused on the abnormality. Okay, so that was where we could get the insurers to pay for it because there was pretty good data. It was actually in our NCCN guidelines for men with prior negative biopsies. The precision trial was published in New England Journal of Medicine, May 2018. Randomized trial, 500 men, randomized to getting an MRI before prostate biopsy versus a standard Trussen biopsy. And interestingly, that's the first time in a biopsy-naive cohort, men who've never had a biopsy, that we proved that doing the MRI first improved outcomes. greater number of men diagnosed with high-risk prostate cancer, which is the goal of biopsy, and lower number of men diagnosed with low-grade prostate cancer. So it helped in both. It diminished overdiagnosis and improved diagnosis of high-risk disease. So now the standard of care is to do an MRI before the first biopsy. When I say the standard of care, I mean it's now in the AUA, NCCN, and European guidelines. That means the insurers have to pay for it. And if they don't, and this is our weekly drill. Anybody from an insurance company here? Okay. Yeah. So I have, those of you who know my practice, Sherry Faramond is an absolute angel. She does all of my scheduling and answers phones and does all this stuff and battles with insurance companies. She estimates that 60% of her time is doing auths and re-reviews of denied benefits. So I have a staff member that just spends an enormous amount of time and money doing this. The game is to say no, and then we write letters, and then eventually we get to yes after the patient and my staff are annoyed for a few months. So I wish it was a different system, but we're not there today. We'll hold the question. Anyway, Sherry's an angel, so those of you who I've seen in practice, thank her. Okay, MRI. We're proud to be a leader in MRI and the technology. We have a great research team. Anders Dale is really the scientist who invented RSI technology, looking at brain tumors, actually. He's a PhD scientist. David Caro, fantastic radiologist. He's now CEO of HLI, Human Longevity. So he still has a faculty appointment, but he's running the Human Longevity Institute. But we translated that technology into diagnosing prostate cancer. It's now the community standard to do this RSI technology. So we're really proud that we think we made a contribution that helps men. High RSI, high PIRAD score strongly correlates with high-grade disease. And this is a classic from one of our papers. This shows T2 weighted image. It shouldn't be that dark. This anterior spot. This is the ADC map, also showing abnormalities here. And this is when we apply the RSI technology. Look how clear it is. We call that conspicuity. Conspicuity means it's obvious. It's easy for and that's important because we're taking care of a lot of men every day. It's easy for a radiologist to miss something that subtle. And so when we have a technology that really makes it jump out at us, we're less likely to miss it. When I have to do a biopsy on this, that's pretty easy to hit. Okay. This is about risk stratification. So, I talked about PSA grade and stage and risk stratification, low risk, intermediate risk, high risk. But the reality is this intermediate risk patient is challenging because there's a wide variation in outcomes of intermediate risk prostate cancer. Low volume 3/4s, there's some men I followed on what we call extended indication active surveillance, and it's amazing how some of the men don't seem to change over time. 10 years later, their PSA is the same, the tumor looks the same on MRI. So there's a group of men with low volume 3/4 disease that don't seem to progress, and I've taken care of men with Gleason grade 3/4 disease that rapidly progress, that all of a sudden become difficult to treat within relatively short intervals. So there's a wide biologic variation of this intermediate risk group, and it's really the sweet spot of genomic testing, I think, to try to understand who is likely to benefit from intervention. And this is just the point. If we look at AUA, intermediate risk men, this is the intermediate, this is the low risk, this is the high risk, and this is the risk, and this is how we can distribute. So this is each one of these boxes is an individual man, and this is if you add Prolaris, they were all clinical intermediate risk, but their actual risk could get spread out pretty dramatically from very high risk to pretty darn low risk. And this is a group of 3+4 PSA 10 to 20. So the genomic testing does a pretty good job of figuring out among these intermediate risk men who's really at risk and who really isn't, or is it less risk? Okay, Changing paradigm in high-risk disease. So I'm going to make a couple controversial statements now, and I'll back them up. But I want to introduce some statistical, comments. So changing paradigm in high-risk disease. Surgery may be superior to radiation or ADT alone for high-risk clinically localized prostate cancer. Why do I say that? Well, there's 3 large studies where we've looked at men who have advanced prostate cancer. I should say looked at populations of men with prostate cancer, and then looked back at their first treatment. And when a man's first treatment was surgery, the death rate appeared lower for populations 15 years after treatment. Now again, we should be cautious. These are relatively small differences. I'm going to introduce a concept of relative risk so we're clear about this. The number of men with high-risk prostate cancer, we're talking about PSA over 20, Gleason 4+4 or higher disease or T3 disease, the number of men who die from prostate cancer at 15 years in these studies is around 10%. So it's not and the difference between starting with radiation and starting with surgeries, only about the relative risk is about 0.5. So it's 5% to 10% risk of mortality difference. So the absolute risk difference is small, 5%. Only 10% are dying from prostate cancer. About 5% of the men who started with surgery, about 10% of the men that started with radiation. So the absolute difference is small. The relative risk is large. The men who started with surgery only had about half the death rate as the men who started with radiation. So that's why this term relative risk is important. For instance, we could have situations, this is true of this study, all 3 studies, the intermediate risk men only had about a 4% risk of death at 15 years, but their risk was about half if they'd started with surgery. So what are the possible explanations? These are 3 large studies looking at thousands of men. What are the explanations for that? One is surgery is better than radiation? Probably not, actually. One explanation is maybe the men who started with surgery were healthier. And when you start healthier, your risk of dying 15 years later is lower. So that's a good one. So we tried to risk stratify these studies and look at cardiac risk, et cetera. So we tried to control for that, but without a randomized trial, you really can't perfectly control for it. I think the reason is that men with higher risk disease probably benefit from effective multimodal treatment. If you look at the men who had prostate cancer who had high-risk disease, many of them also got radiation therapy and ADT. They just got it after surgery. When you start with surgery, you're more likely to get surgery followed by radiation and ADT. When you start with radiation, you're more likely to just get ADT as salvage, and that first strategy might be a little bit better. So I don't think it's a comment that surgery is better than radiation. It probably is more that multimodal treatment might be better for men with high-risk disease up front. And that's with the caveat that we're not talking about side effects. Those men who start with surgery probably have a worse profile of side effects. They're at risk for urinary incontinence, at risk for sexual dysfunction. So I'm just talking about cancer treatment effectiveness. We know when we have high-risk localized prostate cancer, ADT alone is not effective, not as effective as ADT plus radiation or ADT plus or minus surgery. So that is now very well known. The CAPTURE database has shown us that the ADT alone group doesn't do well. So this is why I argue with some of our colleagues in Southern California who are real ADT advocates, even for localized disease. I think the data does not support that. Now that was a controversial statement. We can argue for hours about that. Okay. Addition to docetaxel or ABI to initial ADT approves overall survival in M1 disease. M1 means newly diagnosed metastatic disease. How long have we known this? 1 year. We've only known that for 1 year. The randomized trials, these are newly diagnosed metastatic disease, meaning hormonally sensitive or castrate-sensitive disease. Somebody walks in the office, their first PSA is 200, their first bone scan shows metastases. That's the man we're talking about. Now we know that upfront docetaxel with ADT or upfront ABI with ADT improves outcomes. That's this year's information. In the past, Abi and docetaxel were approved in what cohort of men? Men when hormonal therapy is failing. We call that castrate-resistant disease. When they've been on ADT or intermittent ADT, PSA is rising. That's where we approved. Those were the trials were that approved Abi and enzalutamide. So now we know up front it's better. How about treatment of the primary and low-burden metastatic castrate-sensitive prostate cancer? Think about that same man. First PSA is 200. Bone scan shows metastases. He's got a little bit of urinary difficulty now. In retrospect, on rectal exam, he has a mass in his prostate. So he's got prostate cancer in the prostate. He has bone metastases. PSA is 200. We know we're going to treat him with abiraterone and ADT. We know that's the right treatment. Should we treat his prostate? Is there value to giving him radiation therapy to the prostate or not? We don't know. That trial has never been done. So the treatment of localized disease for a man with newly diagnosed advanced disease, the answer is we don't know. So that trial is being done now. I'll show you some retrospective data that suggests the primary tumor should be treated. How about salvage therapies for oligomets? This is a man, radical prostatectomy for intermediate risk disease. 5 years later, the PSA starts to rise, has salvage radiation. PSA goes down. 3 years later, PSA starts to rise again. Gets a PSA membrane antigen PET scan, one spot in a lymph node, para-aortic. Is it worthwhile to treat that with radiation or surgery? We don't know. Randomized trial being for that group of men. I bet you there's some people in the audience in that category. Yeah. All right. And now I always talk too much. So I'm going to go and just summarize a couple of important studies that back up some of the statements that I made. Okay? This is called the Scandinavian Working Group 7 study. This is a retrospective review of the National Cancer Database for people with clinical node-positive disease without distant mets. Clinical node-positive means a CAT scan shows large lymph nodes, newly diagnosed prostate cancer, but no bone metastases. And looked at how those men were treated. ADT alone was compared to ADT plus radiation. 10 years ago or 20 years ago when I was in training, those men were considered to have metastatic disease, and our recommendation was ADT or intermittent ADT alone. Now the question is, should we be treating them with ADT plus radiation to the prostate? Well, it turns out ADT plus radiation was associated with a 50% lower 5-year all-cause mortality, hazard ratio 0.5. Remember this concept of relative risk? Half the risk of death. This is the so that was a retrospective review. This is a randomized trial, high-risk patients, 875, locally advanced, non-metastatic. So most of these men had big tumors. PSA could be under 70. Standard imaging, remember if we did sophisticated imaging, many of these men had metastatic disease, right? If we did PSA membrane antigen, we'd see little spots with modern imaging on these men. 90% high-risk prostate cancer. 3 months of combined androgen blockade followed by flutamide versus that same ADT plus radiation to the prostate. This just shows they were well-balanced groups. This is, again, this relative risk concept. Okay, this is incidence of death from prostate cancer. So notice, 40% of the men with hormonal therapy alone died of prostate cancer by 16 years. Only 20% of the men who had the radiation to the prostate died. Relative risk 0.5. Huge power. So think about that. These are men PSA 50, 60. Modern imaging probably showed a little microscopic metastases. The only difference that created this good outcome is treating the prostate. This is incidence of death from any cause. We always have to look at overall mortality because maybe the men who had radiation acquired some risk that may give them a higher risk of heart attack or something. So their prostate cancer mortality might look favorable, but they acquired something risky. And the difference persists for all-cause mortality. And this is called a forest plot looking at which men seem to benefit. If they're on this side of this line, they benefited from radiation. If they're on this side of the line, they didn't seem to benefit from radiation. And the men with lower risk prostate cancer didn't benefit as much. they weren't at high risk of death. Okay. So that is one of the pieces of data that now we look at, we say, looks like treating the prostate makes a difference. So we should prove that. If we really think it makes a difference, we better prove it so it's in clinical trials and it's in the guidelines. These are retrospective reviews of men who have no treatment to the primary, radiation to the primary, or radical prostatectomy for newly diagnosed metastatic disease, and this is their outcomes over time. And again, these are 3 different sets of retrospective reviews published in the literature showing that treatment of the primary tumor with either surgery or radiation seemed better than no treatment at all for men with metastatic disease. So now we randomize it, we do a trial. This is the way we prove it, to overcome all the potential biases of these retrospective reviews. So we enroll, these are men with newly diagnosed metastases. They get standard systemic therapy or definitive treatment, it could be surgery or radiation to the prostate, versus standard systemic treatment alone. And then we look at progression and survival. Now the challenge is, when we start to accumulate evidence like this, even though it's not the highest quality evidence, it's hard to have equipoise. If I have someone who comes to me and they say, Dr. Kane, if it was you, what would you do? It's very hard for me to enroll them in the trial because I'm now a believer having reviewed the data. And this is a challenge kind of intellectually. We haven't proven it. We won't get this approved as the standard of care until we do the trial. So when we do these trials, I always like to see an escape clause, and I like the safety monitoring board looking at the outcomes of these men randomized to what may be the less favorable arm so they can get crossed over into the favorable arm. It's why we put patients on our study design groups for that reason, because we have to really keep faith with every man enrolled in that trial to make sure that we're not exposing them to risk. So this is now open. Okay, how about PET to identify and target oligometastases? I think all of you know that now we've got this amazing PET imaging, PSA membrane PET imaging. It's still undergoing review by the FDA. We have two centers in California that are doing it, UCLA and UCSF. It's probably going to get FDA approved this year or next year, and then it'll be fairly widespread. And this is a man who had a radical prostatectomy 11 years ago, PSA increased, started on ADT by a urologist, had a PSA membrane PET, that's a positive node, had a salvage lymph node dissection, and then 18 months post-op is PSA 0. Someone used the term cure earlier. We don't say that patient's cured. Cure, in oncology treatment, we'll never use that term, or very rarely use that term, because cure implies knowledge of the future. And we're not God, we don't know. We use the term no evidence of disease, and we risk stratify patients for their risk of recurrence. So that's a more common and probably a better way to think about it. So you'll not see very many oncologists use the term cure. Disease-free today is a pretty good goal. Disease-free and off therapy, that's an even better goal. So I'm going to go through this because I'm almost out of time. When we look at salvage lymph node dissection, now we've done quite a few of these, and patients come in this situation, what's the chance if I have a salvage node dissection that I'm going to be cured, that I'm going to have an effective outcome, that I'll at least be disease-free? And the answer is, if we're doing the salvage node dissection when your PSA recurrence is fairly early, about 1/3 of men will be disease-free after the salvage node dissection. 2/3 will have a persistently elevated PSA. And these are the 2 studies, one done at Mayo Clinic, and again, I'm just going to go to the punchline. So the median PSA at the time of salvage node dissection was 2. You have to do a good lymph node dissection. Median number of positive nodes, 3. Remember, this is a salvage setting. 5-year biochemical disease-free survival, 30%. That means a PSA of 0 5 years later. However, so remember, that's salvage node dissection PSA at 2. And then if we look at European data, this is Christian Stief. He's the senior author here, and he's in Munich, and they run a huge prostate cancer center, very high quality. They were doing salvage node dissections at a mean PSA of 9.8. Well, do you think it was more or less effective at that PSA? Less effective. More men had more widespread metastatic disease. Median number of lymph nodes removed, 18. Median number of positive lymph nodes, twice as many. 5-year disease-free, 0. So if you're going to do a salvage node dissection, you better do it early. You better do it early. And it should be focused on men who have a low volume of disease on imaging to really be of utility. Okay, how about oligomets? We don't know. Here's an example of a patient, almost similar to that patient I just mentioned I cared for last week. Radical prostatectomy 2012, Gleason 9, node positive, PSA increased, had ADT and salvage radiation, had a second relapse, had a PSA membrane antigen. This time, instead of a node popping up, that's a bone met. That's a bone metastases in the L5 vertebrae, but we only see one. So he got radiation therapy on the COMET trial, and he had a great response to radiation, but he is on ADT, so it's hard for us to really judge that PSA. So this is a randomized trial for PET-diagnosed metastatic disease. And this is just so we remember where we came from. There's a lot of new treatments that have been approved in these last 5 years because of research. The outcome of men newly diagnosed and recurrent is better today than ever in the developed world. The CHARTED trial proves that docetaxel should be used with ADT. The STAMPEDE and LATITUDE trials prove the same thing with abiraterone. And again, this is kind of the landscape of treatment of advanced disease. And you probably saw that apalutamide, really kind of a cousin to enzalutamide, was just approved. So we have a lot more in the armamentarium, 7 new drugs approved for metastatic castrate-resistant prostate cancer since 2004. So there's a lot of hope, a lot of hope. A lot of men diagnosed with high-risk or advanced disease, alive many, many years because of effective treatment. Prostate cancer research making huge progress. Improved detection of risky cancers with MRI, improved imaging of local and distant disease, new treatments for advanced disease, better understanding of resistance and personalized treatment. Please support investing in research. Be cared for by experts and coordinated clinical teams. There's good evidence that high-volume teams at high-volume centers, whether it's surgery, radiation therapy, treatment of advanced disease, have better outcomes. So when people say, where should I be treated? I say, high-volume team, coordinated care. That's where the data is. We have that at UCSD, but other places have it too. So get cared for by coordinated teams. That's it. I hope it was useful.
Thank you. Wow, that was very informative.
Sure.
And I want to emphasize a point about these centers where there's a lot of treatment going on. The Urological Association reports that 80% of the urologists do only 8 prostate cancers a year. You don't want to go to a doctor that only does 8 a year. It takes 250 to develop a degree of proficiency in a year. So you want to go to a high volume doctor who does this, and those are at the centers. Okay, we're going to have some questions for Dr. Kane. Let's start here if he's ready. Okay, let's start. Any questions here? Okay. All right, yes.
I have a dear, can you hear me?
I can hear you.
Thanks. I have a dear friend who just discovered his PSA is 900. They know there's metastasis. These on his pubic bone. That's all he knows right now. Is there, so these new meds, any testing for that high?
Yeah, no, that's newly diagnosed M1 prostate cancer. The treatment has just changed this year for him, and it's associated with better outcomes, better survival, and it's hard to make a recommendation on a brief comment like that, but he should be seen at a high-volume center that has a medical oncologist and a coordinated team. And so if he is a San Diegan, of course, we're glad to see him. If he's not in San Diego, he should go to a comprehensive cancer center where clinical trials are available. He would likely be enrolled at our center in that randomized trial I just mentioned that would put him on androgen deprivation therapy or abiraterone and docetaxel, and then consider whether his prostate should be treated with radiation therapy or surgery. Usually radiation therapy when your PSA is 800, but not always. That won't, so when we look at complementary therapies, you know, I rode my bike this morning. I have the largest friends and family team for Pedal the Cause. I'm a fitness buff. I'm a Californian, so I take my vitamins. But when we look at people who really embrace complementary therapies, the most common thing we see in their outcomes is a delay to effective treatment. So I use the term complementary, not alternative. So exercise, eating well, taking good care of your emotional health, which is difficult in a moment of crisis like being diagnosed with prostate cancer, that I embrace. But him taking high-dose vitamins instead of getting definitive treatment, that is folly, and it's associated with worse outcomes.
Be in the way, though, of being a part of your trial?
It could be. We sometimes have to stop therapies that have a physiologic impact. So for instance, before surgery, I ask people to stop ginkgo biloba if they're on ginkgo, because it's associated with higher bleeding risk. So yeah, some of the complementary therapies we do have to be a little careful of.
Okay, questions here? Okay.
How much does UCSD coordinate with UCSF and UCLA on things that are available?
Great.
Here, not here, et cetera?
That's a great question. We actually have a UC Health. Yeah, the question is, how much do we coordinate with UCSF, UCLA, UC Irvine, UC Davis? There's 5 UC campuses. There really is a relatively new initiative just over the past couple of years for the UCs to get together in a UC Health Cancer Consortium to make sure that the clinical trials available at each center is available at others. And that's not easy. The infrastructure of standing up a clinical trial requires quite a bit of review, but that's happening right now. And I would say our comprehensive cancer center is every bit as high quality and superior in some domains to the comprehensive cancer center at UCLA and UCSF. UCSF has a great prostate cancer program. That's where I was there prior to coming here. And so Eric Small and Peter Carroll and Mac Roach are good friends and colleagues. Our prostate cancer therapies are as effective as anything happening at UCSF. So we're pretty confident. They do have a very good and robust basic science research program. They had a prostate spore a number of years ago. That's called a specialized program of research excellence, 5 big grants. And so they've done some fantastic things. I'm not being critical of them, but when I look at the quality of our medical oncology, our array of clinical trials, the quality of surgery and radiation oncology, we're equal to them.
Questions over here? Over there? Any over here?
Yes, sir.
Okay, now we're here. Here we go. Mike?
Sorry.
Great presentation, and this is more of a statement than a question of complimenting UCSD, I think Dr. Kane, for recurring prostate cancer, being treated with radiation before and then 6 years later. Looked at brachytherapy, and he actually said, look, in your case, the brachy we do at UCSD is not going to be effective. You should do HDR.
Yeah.
The birth rate at UCLA
Great.
had HDR done.
Great.
Very high success rate to it.
Yeah.
It's truly a pain in the butt, but it's a successful treatment. So I'd compliment that they're willing to refer outside of your team.
That's I appreciate the compliment. John Eink, is a colleague, friend, and I have a lot of confidence in him. He actually was in practice trained up at the Seattle Prostate Center with John Blasco and that team. And so he's a real expert in brachytherapy, but I think he's right. When you get beyond kind of intermediate volume, intermediate risk disease, the data is a little stronger now for HDR. And many of you probably don't know what HDR is. It's where we actually put tubes in the prostate and then put radioactive material in those tubes. But HDR stands for high dose rate. It's a very high dose, limited time exposure, and we usually do it repeatedly over a period of days. So it really is a surgical procedure. You have to be an inpatient. You have these devices inside you, but they're not permanent like the radioactive seeds. So it requires specific expertise. We judged that unless we get up into the 50 to 60 HDRs a year, we probably shouldn't do that program, because you need, like I just mentioned, you got to do a lot of it to do it well. So we're okay we have colleagues at UCLA who do that well, so we're not quite at that volume for the perfect HDL patient. They don't have protons, so we have protons here, so they'll refer patients here for protons. They don't have 2 of our clinical trials open, so so we try to, it gets back to that question, we try to make it visible to patients what we do well and where we're not doing things. We don't do HIFU. I've just made a judgment. I haven't been convinced that the data is that strong. We're actually probably going to launch that this year because there's such high demand for it. But I will only launch that on a clinical trial. I'm not going to just start doing it because it really, I'm concerned about the high local recurrence risk. But that's an example. But I appreciate the compliment, and John Ike has my complete confidence.
Okay, question back there. Yes?
What's the downside for doing a radical robotic prostatectomy for an early stage 3+3 case? I mean, this is me.
Yeah, the downside is it's not necessary. The goal of any treatment is to reduce the risk of metastases, reduce the risk of death from prostate cancer, or maybe for a patient on active surveillance, maybe he doesn't want repeated testing. So I would say the only advantage of treating low-grade disease is if the burden of the knowledge of the disease and the burden of follow-up feels overwhelming to you. And there are some patients where every clinical visit is an emotional event for them, and it's really tough. And the idea they have to get an MRI and they might have to get repeat biopsies, they really don't like that. So we'll sometimes treat men with low-risk disease, but in general, I try and encourage men to accept active surveillance. And we're now discovering a group of men where the surveillance can be a little less active. For instance, if they're diagnosed with low-risk disease and they fit all of the criteria I mentioned, PSA under 10, low PSA density, low volume of Gleason 3+3, and we follow them, we do a confirmatory biopsy and MRI within 1 year. That's a very important part of that because we misclassify patients 25% of the time as low risk. So we definitely want to do that confirmatory MRI and biopsy. But then, as we're following men, if nothing changes, we can now predict the men likely to progress over time. I will get out to MRIs every 2 to 4 years and a biopsy every 4 years. So we'll stretch out and do less active surveillance for the men we think are really in a low-risk category. So that's evolving over time. So, and you won't know that until you've resisted the emotional temptation to be treated. So I would encourage you to hang in there. People ask, what would I do if I had low-risk disease? I'd go on surveillance, and I'd negotiate, how frequently to be tested.
Hey, Dr. Kane, you're at your cutoff point. You're allowed one more question?
Yes, sir.
Okay.
You mentioned the RSI MRI. Is it still in clinical trial? I mean, in a trial, or is it now a clinical scan?
Clinical scan that everybody gets. The question was, I mentioned RSI for prostate at UCSD. Everybody having a prostate-focused test with localized disease or recurrence has a 3 Tesla MR, no endorectal coil with RSI technology. That's our standard test.
How many patients?
Oh, now it's 2,000. Yeah, it's big. It's a big number. Yeah, I think we do about 600 a year now.
Dr. Kane, and your presentation said 30,000 deaths every year. That's a high figure, I thought. Is that figure going up? I always thought it was 28 or 27.
It is about 28 this year. That was, I think, 2016 data.
Okay, so
I think it is
going down.
It is going down a little bit. It's 28,000 this year, I think.
All right, let's get a round of applause here for Dr. Kane.
Thanks.
And the DVD of his talk and the charts and the details and all that are going to be available next month and at a nominal fee of just $10. So there's tremendous amount of information that was given today, a lot of new stuff, and so we really appreciate his ability to come in for a quick visit. Now we have some more information for you, so hang in there. And
My pleasure. My pleasure. Good seeing you.
Chuck, could you put the flash drive in for me? Thank you. Have a good day. Thanks a lot.
Thanks, everyone. Appreciate it. Thanks. Oh,
I hope you appreciate how this group is able to attract such top doctors here and other parts. So after we have Dr. Rossi, and then we have Dr. Almeida from Phoenix, and closing out the year in November, Dr. Richard Lamb from up in Marina del Rey. So these are all top-notch, nationally known people that really enjoy coming down here. I debriefed them after the meeting, and they really like your questions. It's a pretty smart group. Don't let it get to your head. But they enjoy the opportunity to speak before this group. We're very well known as a good group that they benefit from. It's impressive activity that we have here. Okay, you've seen this stuff before. Here's the 10 people that work hard at this and make it good. Now, the newcomer package, did all the people that were new bring it down here at the podium when the meeting ends. Okay. This is a good demonstration today what our support group is about. It's to help you become your own case manager, and by that I mean your ability to hear a doctor and also to do some networking of the other members of the group, and I'll be commenting specifically on that, and in a caring, positive environment. Years ago, when I asked the urologist if I should go to a support group, he said no. I said, no, why? He said, oh, they're a bunch of whiners. And initially I thought it was a cheese and wine group, but no, we try to generate a positive effect here, but we're not a substitute for your doctor. What you hear today, even from a doctor, should not be a substitute for your own doctor. What we hope we do is raise questions that you might want to ask your doctor. And I have found, after listening to the presentations here, I go to my doctors and say, what about such and such? Oh, yeah, we could do that. Well, if I hadn't brought it up, we wouldn't have done it. So there's that value we get. Okay, a lot of material we have here. Bill Bailey has a wonderful collection of library material you want to scan when you exit here. We have a great newsletter that is produced by two gentlemen here that are volunteers. And then we have an outreach program, monthly meetings. Here's our next speaker, Dr. Rossi. And okay, what I want to emphasize is the case management is the key thing that you need to do and get your lab reports. And let me flip through here now. Okay, so here's our case management thing that we want to emphasize. These are 6 elements, and we try to get each speakers to fill out these 6. And you've heard about early detection today. You also heard about high definition. Didn't hear about targeted biopsy, but he's a supporter of that. Know your Gleason score, and he's a big fan of active surveillance, and you've heard a lot about treatment selection. So we've covered the bases pretty good here today. And then you've already given your donation. Now, a special report. This is breaking good news. You've heard of breaking bad news on CNN. What we have is the good news, and you saw a little bit of it on his chart. Apalutamide. How many of you are familiar with that? Was the last new discovery. I'm going to stand still here. It works. It was just approved in February, and it has a brand name of Erleada, developed by Johnson & Johnson, no relationship. It's the first drug for men with NMCRPC. Now, what the heck is that? Well, underneath that's non-metastatic castrate-resistant prostate cancer. Non-metastatic prostate cancer. In other words, it has not spread to remote areas. Now, the trade name of Erleada is an androgen receptor inhibitor. What the heck is that? I love my friend Gene's definition. It's like a duct tape being put on each cancer cell. It prevents the testosterone from initiating and stimulating the cancer cells. You still will have testosterone, but it prevents it from acting on the cancer cells. And it's similar to Xtandi. The bottom then is similar in side effects. For some, severe fatigue and severe cost. I'm familiar with both because I've been taking it. How much does it cost? It depends. They say $10 a month. That's if you don't have Medicare, if you don't use Medicare. And I have not had anybody check that out yet. But if you are on Medicare, the cost to you as an individual depends upon your supplemental insurance and some other things. You might get foundation support. It costs $10,000 a month. So when you get your first treatment, first month, bingo, you're in a donut hole in Medicare. And so you end up paying, like I do, $600 a month and for treatment and so forth. Now they have a savings plan down at the bottom. They will cover your cost if you're not on Medicare. So that's an advantage of not being on Medicare. But always ask your doctor how much. I want to share with you personal experience. I've had prostate cancer for 20 years. I've had a very aggressive cancer. My Gleason is 9+, if not 10. And I have a doubling of the cancer is 3 months. Every 3 months it will double unless I'm on some effective treatment. I have now, because of the 20 years, undifferentiated cancer cells. You've seen that cartoon showing nice little small cells in Gleason 1 going to a Gleason 5 with those big massive things. Well, there's another one in there where the cells are totally undifferentiated. Looks like a sand. There's no cell structure. That's what I got. So what it is, it's a very unusual form, a very advanced stage, also very aggressive, and it does not generate the antigen like normal cancer cells. So it misdirects you on the PSA. My PSA basically has not risen in the last 5 years, but my cancer has. So it's not a good marker. Maybe temporarily it is. Okay. So my cancer spread throughout my pelvic region. And on April 20th, April of this year, it was through an MRI to have invaded into my rectum. Apalutamide causes a dry throat too. Okay, so it's a rare and dangerous pathway with medically stated as miserable outcomes. Wow. It is in my pelvic area. It's in my bladder and all through the region and into my rectum. But it has not metastasized. And so therefore, I don't qualify for all those new drugs. And so there comes out apalutamide in April. I was one of the first to get it. Otherwise, I would have been taking, if it had metastasized, I could have had those other drugs, Zytiga, Provenge, Zofigo, Xtandi, and I was not able to get that because it's not metastasized. It's it's growing in the continental USA, except I don't qualify because I don't have it in Alaska, and the lymph nodes and bone. That's the deficiency of the FDA testing. If you're going to do it, why do they limit it to metastasized only? So what happened was I talked to my doctor, and there's this new thing called apalutamide, and so he put me on it, unsure what it would cost me. 4 huge pills. They're very ugly, by the way. If you're going to pay, each pill is almost $300. And if you're going to pay you'd like it to be kind of shiny or, nice colors or something. This is olive drab pill. It's not very attractive. So, before I went on it, I went and had an endoscopic exam. And that's the report from around the corner here, the La Jolla Endoscopic Center. And you can't see the elements there or read it, but I'll just point out to you that the doctor finds a nodule there and is concerned about it rupturing, and with my being on blood thinners, bleeding. And of course, now, by the way, he had never seen prostate cancer in the rectum. It's very rare. There's an unusual barrier that our higher power created to prevent the prostate, which is nestled right by the rectum, from growing into it. Of 29,000, so I don't want to alarm you now, but here's the statistic. Of 29,000 cancers in the rectum, 29,000 men, only 9 had prostate cancer. So you probably won't get it. But there's an example here. There it is. There it is. This is not a detailed photo that I could show you where you can see the veins in more detail, and that was the doctor's concern. Now, this doctor is a gastroenterologist, not a urologist. So he deals with the digestive tract. So when he says, oh my goodness, he's never seen one before. He's been practicing for 40 years, never seen one. And I said, well, what are we going to do? He says, go see your urologist. He doesn't do anything about that. That's it. Well, I went back, and then I got the apalutamide. And I asked for a test on it, and on my own, I went back to this guy yesterday. And there's that picture, and here's a comparison now. Here's before and after. There it is, and now it's here. It's shrunk in half in 4 months. Apalutamide. Orlita. It works. Now the doctor, maybe it's because he's German when he did this. See, this is just yesterday. I'm looking at on the screen. Oh my goodness, it's smaller. Isn't it smaller? I'll send you the report next week. Well, it looks really small. I'll send you the report next week. Now, the PAs and nurses were elated. So when I got out of there, they were happy for me and so forth. So they're the ones that really know what's going on. So here's what happened. Apalutamide works for me. It reduced the size to 1/2, 1/3 in 4 months. The biopsy details will be next week. When I first went in, because I'm worrying about bleeding, because I bleed a lot, so this time I asked for one. So he did one. Now because of the success, they will reduce the medication to half. Instead of 4 pills a day, I will have 2, which is good, and it will save me half the cost. I'm going to continue to insist on getting this exam. And now, the problem here is I had to insist on having this. They did an MRI, and our good friend from Imaging Health, Ross Schwartzberg, yeah, good guy. He did it. It was a 3-tester, super duper. And he says, it looks like it might have invaded, but I can't for sure tell you that. So I said, should I get a rectal exam? Yeah, you could do that. Now, my doctor, when I said, hey, I think it's looking good, shouldn't I get another endoscopic exam? No, I want you to get an MRI. And my point, an MRI, that's the one that didn't really show it. How about an endoscopic? No, I want you to get an MRI. I said, when? He said, October. So yesterday I went to endoscopic. So here's an example of case management. So I want to show you what I've learned in this group, my case management effectiveness. 2 years ago, I had to request consideration of a TURP. I had a huge blockage. I had to cancel a trip to Hawaii. I was in terrible pain. The scale was 10. And so what happened when they did the TURP, they removed a lot of tissue, which lowered my PSA in half, because they were removing the generator of PSA, and did basically a biopsy and examined it, and that's when we found out I got a Gleason 9. That's the second biopsy I've had in 20 years. I had one by Dr. Bond after I came to this group 8 years ago. That's all I've had. No doctor has suggested another one, because I had a low PSA. Okay. So then, now we got a problem here, because it also was undifferentiated cancer cells, and which is very bad, as I mentioned before. It understates the PSA. So I'm in worse shape than the doctors thought. And by the way, these are a number of doctors. I just don't go to one. So, okay, they all wanted to give me Lupron, which caused me huge problems when I first got it. And so I have heard from a friend, he's not here today, Denny, said, hey, George, why don't you try Firmagon? So I asked my doctor, how about Firmagon? And guess what he said? Yeah, we could do that. But I had to bring it up. And this is what I learned here. So I got that. You take it once a month. It works and doesn't cause all the problems, particularly heart, that Lupron does. So that was good for me. And then I started saying, well, I got this barrier of it not having metastasized. I kept getting exams done and so forth. No, it hasn't metastasized yet, George. You don't qualify. And then I made some push from how about my paying off-label for Zytiga. And, well, that's going to cost you extra money. And I said, well, let's do it, because it's growing. And so I requested, before I start there, I'm an engineer, I want to see what's happening. Let's do a baseline. First, let's look at the bladder. And so they did a bladder exam. Oh, boy, that's in bad shape. And I say, now I want to do an exam of my pelvic region, an MRI. And that's where Schwartzberg said, you really got a problem there. See, these were impactful exams that were not initiated by my doctor. I'm the one that had to bring it up. What about? How come? And all that. And then I requested the very good MRI, and that was impactful. So then on my own, I did the endoscopic, and now I've had it done 2 times, and that's been impactful. I was going to say you can't imagine. I'm sure you can. How good I felt yesterday at 11:30 after walking out of Dr. Len's office, and the really smiles and cheers I got from the nurses. And I said, "You don't mind if I hop, skip, and jump down the hallway, do you?" And so forth. The relief I felt that, hey, we got a handle on this thing, and all that. So I just want to share your case management, your buddies in this room and the speakers we have, and so forth, does help if you take action on it. So manage your own case, make copies of your lab reports, do all those good things you need to do for you to manage that, and ask your doctor a lot of questions. Okay, a couple of questions maybe, if not. Question.
Could you ask if anyone is taking metformin to help control their PSA?
That's what I have done early on, and I learned that here in this room and up at PCRI. The interesting thing, Dr. Schultz takes it. He doesn't have prostate cancer, but he thinks that has other benefits besides those that people who are on diabetes. It's interesting when I put it down on my list of prescription, everybody assumes I'm diabetic. No, it's not well known to be. There's a test. I haven't heard about the results of the test. There's an extensive trial to occur on that. Who's taking metformin here? Okay, Jack taking it. Okay, any other questions? Yes?
As far as biopsies, how many biopsies have you had?
I've had 2. Yeah, one yesterday and one up in Ventura with Dr. Bond 8 years ago. I can't hear you. This is my puzzle. I'm surprised the doctors. See, I think the thing was that, hey, you're doing good, you look good, your PSA's low. Yeah. See, particularly I'm old, so we're not going to mess with you, and I seem to be doing good, and it hasn't metastasized, so you're in good shape. No, I'm not, but I've got a better path forward now. Yes.
This non-metastatic castrate-resistant prostate cancer seems like a pretty unusual case. What percentage of prostate cancer cases falls into that classification?
They don't know. See, it is a category for FDA to test. You have to have it metastasized before they'll test the drug. On the advanced drugs, they don't say we want people who haven't metastasized, but it's growing. It's just a big void there, and that's true with urologists. They just don't. I guess I was supposed to wait for it to metastasize. Now, one good news thing is Xtandi has now been approved for non-metastasized. This is now the last PCRI conference. I think you were there. It was a new subject. But I don't think they have the statistics on it yet. So what I may be talking about is rather rare, but their stock went up very great. So there's a market for Erlita and things like that. Yes?
So if it's not metastasized, what's the pathway for its migration?
It's not good.
No, I mean, what is the pathway? Is the metastasis sort of...
Well, in my case, it's in the rectum, and that's about the worst thing to do because the only way to treat that is to gut meat.
They say this is a spontaneous prostate cell, which is in the wrong place, and there's no...
It's unusual. It's called an invasion. It's called an invasion. Yeah. It spreads. It's contiguous, and the definition of metastasizing is remote. It'll eventually get to the bones, but
Right, but it's so much, as you say, it's actually part of a total. It's the original prostate.
Right.
Which is not migrated, as you say, but, well, it's just extended.
yes, it's quite a good question. It's just growing in there and growing throughout my whole arena and not generating much prostate-specific antigen in doing so. So that's why I have a low PSA, hooray. And my PSA is undetectable, but it's still growing. See, this is where maybe I'm the only guy in the world with that, but the thing is if with your doctors, ask the questions. Okay, let's wrap it up. I want to thank you for your attendance. I thought we had a very good speaker, and I think we need to inform our friends that he did a super job, and it wasn't just all about surgery. And he put radiation in a good light. Doctor, I gotta just, it's special that he comes here because he had heard from some of my members years ago that this group is against surgery, and so he didn't want to come. And Gene made some noble efforts to get him in here, and I'm sure he had a very good feeling about this group, and you're going to thank him personally, yes. And thank you for having him come here. Okay, guys, you're free to go. Have a good day.